Emily, Katie, and I are all lawyers at Feldsman+Tucker+Leifer+Fidell, also referred to as FTLS. FTLF is General Counsel to the National Association of Community Health Centers and has an expertise, a commitment in working primarily with safety net providers. So in addition to working extensively with health centers, which I'll refer to interchangeably, as will Emily, as FQHCs, we frequently work with Ryan White providers, Title X providers, community behavioral health centers, Head Start organizations, you name it. So extensive work with a particular focus on health centers. That's going to be the focus of our conversation today. So the agenda, we're really breaking it into three big buckets. We're just going to give you a very brief history of the health center program, as well as a summary of some of the benefits of the health center program. We don't have time to go terribly in depth, so we're just going to give you the hot topics, the key points, and then last but not least, we're going to delve into the requirements of the health center program, which is the real meat of the presentations in terms of understanding the parameters under which health centers operate. It's a federal program. It's highly regulated. I'm sure everybody listening is familiar with both of those concepts, but it's a great place to begin if you want to learn more about health centers, is understand the regulation, statute, and agency guidance issued that really regulate what a health center can do, what must do, and what is prohibited from doing. So with that, I'll pass it on to Emily. Emily, just say a quick next slide when you want me to forward things on. Oh, quick disclaimer, of course. We're just providing general information. We're not furnishing specific legal advice. And that if you do have follow-up questions that would possibly require an attorney, contact a local qualified legal counsel for recommendations. But my hope is that I'm going to give all of you many resources so you can learn more on your own. But of course, we're going to leave about 15 minutes, we hope, at the end for questions. I need to just watch my time because I know we fell back a little bit. Oh, not much. Okay, so Emily, I will pass it to you.
Great. Thanks, Carrie. So to start in this first session, I'm going to go over a little bit of history about the health center program and provide a snapshot of what it looks like today. We get a lot of questions about the evolution of the health center program and its staying power in the healthcare landscape. And actually, the history is pretty interesting. It's particularly helpful in understanding the core requirements and how the model of care developed into the safety net providers you see today. So many would say that the real beginning was about 50 years ago. And spurred on by the war on poverty, the first two neighborhood health centers were created in 1965. There was an urban clinic in Boston, Massachusetts, and then there was a rural site in Mound Bayou, Mississippi. From the start, the health center model operated with a community-based focus. So the idea was that by vesting control of the clinic in the consumers of the clinic's services, you could better engage consumers in their own health care, ultimately empowering the community and yielding more positive health outcomes. And from these two initial sites, the community-oriented model of care has evolved into the vast health center program that we know today. And you can see this on the map on the next slide. So what started as just a demonstration project more than 50 years ago grew into several programs authorized separately, but is now completely just one single program. And currently it's funded at more than $5.1 billion, and that's discretionary and mandatory funds. And that covers over 1,200 health centers and over 9,000 locations throughout the country. Now, when I say 1,200 health centers, I'm referring to the individual organizations themselves. So each health center can have multiple sites, which is how we're able to get to the 9,000 locations. And about 12% of health centers are actually Ryan White Part C grantees. So on this slide, you can see a little bit more of the impact. And this information is from 2013, so it's a little bit dated, but currently health centers are serving nearly 23 million persons across the country. And you'll notice some similarities in the patient population served by Ryan White. About 60% of Ryan White clients have incomes at or below 100% of the federal poverty level, As you can see on this slide, it's about 72% for health centers. And for Ryan White, almost 80% fall under 200% of the federal poverty level, whereas health centers have just over 90%. Now, Ryan White also has a similar underinsured population to health centers, about 30% uninsured and significant underinsured population. And one more thing on this slide, not surprisingly, one major difference has to do with demographics. Historically, health centers have served mostly females, and particularly those of childbearing age, while, of course, Ryan White clients are largely male, it's about 70%, and most are between the ages of 45 to 64. And now we'll go on to the next slide. So before we move on, we'd like to know a little bit more about you. We're going to do a quick poll. The question is, are you currently with an organization designated as an FQHC, either as a grantee or a lookalike? We'll give you about a little while to respond. Okay, so it looks like we have a few health centers on the line and quite a bit who are not health centers and a few who don't know, and that's fine. So now we'll move on and talk about what exactly is a federally qualified health center, or FQHC. So in many respects, health centers are very similar to other ambulatory care providers, and they provide substantially the same types of services that you would expect of any primary care provider. But they differ in a few notable ways. The many requirements they have to fulfill that we're going to talk about a little bit later, the unique benefits they receive, and the wide range of services that they must provide. So FQHCs are a corporate entity designated through the Health Resources and Services Administration, or HRSA, that's within the Department of Health and Human Services. And there are more or less two types of health centers, grantees and lookalikes. First, grantees are organizations that meet all of the health center requirements and have successfully applied for and been awarded grant funding from HRSA through a competitive bid process. And so-called lookalikes are organizations that meet all the same requirements as the grantees, but they don't actually receive any grant funding. Now, lookalikes must still apply to be designated as a lookalike, but the process is not competitive. It's just a rolling application. So this is a little different from the Ryan White program in that there is a non-grantee status. We'll get a little more into the differences in our next webinar, but for now, it's important just to understand that there is a distinction, but that both grantees and lookalikes are both technically FQHCs. They have to satisfy certain statutory, regulatory, and programmatic requirements, and they receive the health center benefits. Now, I should mention that usually organizations must be nonprofit and tax exempt to be eligible for health center status. However, there is some flexibility, and this allows for public entities like local health departments or a public hospital to receive a health center designation. And one other quick note, although most health center grants are for broad populations across all life cycles, some health centers do receive funding to serve certain special populations. So, for example, migrant and seasonal farm workers, homeless individuals, and residents of public housing. So as many of you know, there was recently a round of grant awards for new access points. I think that was announced last week. And you might be curious why there weren't many Ryan White programs represented. Now, for one, health center grants are highly, highly competitive. You're competing not only against other organizations that want to become health centers, but you're also competing with existing health centers that are applying for new sites. And they tend to have a bit of a competitive advantage because they're already an established health center. And while being a Ryan White grantee certainly makes you a strong candidate to become a health center, in some ways it can be even more challenging because it's a pretty dramatic change to ensure that you're serving all life cycles and furnishing a broader scope of services. And organizations like Ryan White providers that are targeting particular specialty populations or diseases often find it difficult to shift to fulfilling the broader scope of services for health centers that's mandated under Section 330. So now that we've covered what a health center is, I'm going to talk a little bit about what you all want to hear, which is the benefits of being a health center. So there's a number of benefits associated with the FQHC designation, but today we're just going to talk about 6 key benefits. Now on this first slide, This is a list of benefits that are available to both grantees and lookalikes. Remember, I mentioned that both grantees and lookalikes are considered FQHCs, but there are some important distinctions, and this is one of the first ones. Lookalikes do not get all the same benefits of grantees. So for both, under Medicare and Medicaid, health centers receive payment via a prospective payment system methodology, also known as PPS. And the Medicare prospective payment system is somewhat new. Payments are based on a national rate, but it's adjusted based on the location of where the services are furnished. Now, for Medicaid, there's also some variation across states because instead of PPS, some states use an alternative payment methodology, or APM, that has been approved by CMS. Next is 340B that Ryan White providers may be familiar with. The federal 340B drug discount program requires drug manufacturers to provide outpatient drugs to certain covered entities, like health centers, at discounted prices. So these drugs may be distributed directly by an FQHC pharmacy or through a contract with just your typical retail pharmacy. And again, this is something that both grantees and lookalikes are eligible for. Next, health centers also have access to providers via the National Health Service Corps program. And this program provides scholarships and student loan repayment to support eligible medical, dental, and mental health providers in exchange for service in urban and rural communities identified as health professional shortage areas, or HIPSAs. And by virtue of their location in high-need areas, health centers have automatic HIPSA facility designation. A significant portion of all of the National Health Service Corps program sites are health centers, and nearly half the providers enrolled in the program work at FQHCs. And interestingly, more than half of these clinicians tend to remain in underserved communities after completing their service. Now, finally on this slide, health centers also have access to the federal Vaccines for Children program, which provides vaccines at no cost to children who might not otherwise be vaccinated due to a lack of insurance or an inability to pay. So the second slide on benefits covers benefits that are only available to grantees. First is the Federal Tort Claims Act, and for a few decades now, health centers have been under the protection of FTCA coverage, and this offers significant cost savings. Instead of purchasing separate medical malpractice insurance, health centers may apply to be deemed under the FTCA. And once approved, health center employees and even certain contracted providers and personnel are covered for activities that occur within the health center's approved scope of project. And we'll talk a little bit more about what that means later. Now, finally, health centers also enjoy a safe harbor under the federal anti-kickback statute. Now, this applies to arrangements with other providers for what would otherwise be a donation or a gift, as long as it benefits the medically underserved population served by the grantee. For example, the benefit might be increasing availability of a certain service or increasing the overall quality of services offered. So these essentially donations or gifts can come in many forms. For example, it could be a lease for below the fair market value rate, a grant to defray the cost of care, and this is a significant benefit because it allows other providers like a hospital to feel more comfortable providing a health center with financial or other support without any concern that they might be violating the anti-kickback statute. So as you can imagine, as health centers are a federal health care program, there are a significant amount of regulations that come along. So in this section, we'll go through both the legal authority for the requirements and some of the actual requirements placed on health centers. As you can see on this slide, primarily health centers are regulated through three different sources. The statute listed here, Section 330 of the Public Health Service Act. Second is the implementing regulations. And third is HRSA policy guidance. And HRSA breaks out guidance into two formats: policy information notices, known as PINs, and program assistance letters, known as PALs. And these are all available publicly on the HRSA website, along with other summaries of the other health center requirements. Now, we'd like to point out that we anticipate a sort of mega guidance consolidating a lot of the current HRSA policy to come out this summer. So stay tuned. This will be a significant resource, but it may also include updates to current policy. We move on to the next slide. A few years ago, HRSA came out with what it calls the 19 requirements. Now, there are more than 19, but that's what they call it. And one of the materials that we're going to give you as a resource at the end of this webinar is the guide that describes all of these requirements. Now, they're grouped into 4 sections: need, services, management and finance, and governance. And these are just 4 categories that serve as a framework. And this framework is what HRSA uses to conduct evaluations of health centers, and it helps the health centers themselves figure out how they're supposed to ensure compliance with the program. This next slide lists all the 19 requirements by title, and it shows you how they're grouped into the 4 separate categories. And we're not going to discuss all of these today, but Carrie's going to go over a few that we think are the key ones in just a little bit. Now, if you want more information, as I mentioned, we'd recommend looking at the site visit guide. And this is the main instrument that HRSA uses to audit health center compliance with Section 330 and the other requirements. It includes more detail on each of the 19 requirements that we've been referring to, and it also includes standard yes or no questions that help guide the assessment. Now, health centers have to undergo a site visit once every project period, and during these operational site visits, HRSA reviewers come on site for a couple of days and they review all of the documented policies and procedures, they observe the health center operations, and they speak with various staff and board members. And at the end of this visit, the reviewers will assess the health center's compliance using this site visit guide, and they'll write up a report to HRSA describing whether or not the health center met all the requirements. On this next slide, we've included the first page of the site visit guide. Note that it's periodically updated, so be sure to double check that you're looking at the most recent version. This one was released last fall for fiscal year 2015, but as I just mentioned, we anticipate that there will be a new document this summer that goes into even more detail, so there may be a new site visit guide, or it may be part of this mega guidance that's coming out. As I mentioned, the site visit guide is a great resource to help you understand how health centers must be structured and what they're supposed to be doing to fulfill each of the main requirements. And with that, I'm going to pass the ball over to Carrie to talk a little bit more about the specific requirements.
Thank you, Emily. So I'm really going to focus on 4 key requirements that are really central to the health center program. And by central, I mean they are topics that are of great emphasis by HRSA, have been in place since the foundation of the program, and are of increasing attention by HRSA and emphasis by HRSA. So there's the 4. So 1 being the services, 2 being the quality initiatives. In part, I thought that was also interesting given the Ryan Wade audience and the quality improvement types of activities you have to engage in. 3rd, the charges and discounts. And last but not least, 4th, the board of directors, so the overall governing body for community health centers, which is somewhat unusual. So first we have the scope of required services. This slide lists some of the required services, but not all of them. You'll see it's very comprehensive. So we're talking about screenings, we're talking about primary care, peds, OB, prenatal. We are covering your broad scope of primary care, including preventive dental as well. And this really extends across all life cycles. A health center can furnish additional services, specialty services, if approved by HRSA, if those services are deemed to be appropriate to meet the needs of the population served. So common examples are psychiatry and general cardiology and perhaps more specialized dental services. So a health center has what's called a scope of project, and the services that it provides as an FQHC are a big part of that quote-unquote scope of project. So it is the scope of services is, as I mentioned, required services and then supplemented additional services that have been approved by HRSA. So if a health center changes its scope of services it provides as an FQHC, it has to obtain approval from HRSA, whether it's adding a service or deleting a service. Health centers do not have to provide this broad range of services to all patients at every site. So you can have different sites that have different services furnished. So yesterday, actually, I was speaking to a health center that, is a Ryan White provider as well, and they're in a broad geographic area. And they have one location, 3 hours from a different location, where they furnish just services related to hepatitis and HIV treatment. And HRSA raised concerns that the health center didn't provide access to its full scope of services. Excuse me, I have something in my throat. So while a health center doesn't have to provide all of its services at every site, it has to ensure that all of its patients have reasonable access to its full scope of services. So in that call I had yesterday, the concern HRSA was raising was, you don't furnish all these services at this one particular site directly, that's fine, but if you don't, you need to make sure that you have established arrangements to make sure that all of your patients have reasonable access to the identical scope of services. So you can't have HIV care in the West without any connections for primary care, and at your other site have more extensive services. There are great resources on HRSA on this topic, and we can also answer questions that you may have. The last bullet is really critical here, that a health center, in order to satisfy Section 330 requirements, and just FYI, when we say Section 330, that's the statute, so that's kind of our umbrella term for the HRSA FQHC program requirements. So a health center does not have to furnish the required scope of services directly. It can also have formal arrangements, whether it's referral or by contract, with other providers to document to HRSA, no, we do not provide prenatal, but here are relationships we have with other providers to ensure that our patients have access to the full scope of required FQHC services. Okay. Let's see if I can do this. Okay. So if your organization is not an FQHC, do you currently maintain a referral relationship with an FQHC? We still have some people chiming in, but it appears as though about half don't. 20% do, but it's an informal arrangement. So likely that means nothing in writing. And about the exact same number, 16%, so a little bit less, have a written referral agreement. So it's common for FQHCs to have really any of these, to if it's not located near a Ryan White provider, or it is itself a Ryan White provider, not to have any kind of a referral relationship for purposes of those services. In terms of option B, it's an informal referral arrangement. I would imagine that's quite common because the services furnished by a Ryan White provider aren't required FQHC services under statute, so a health center isn't mandated to have a referral arrangement. Although that's great to know that 1/5 of you have those agreements in place. It's a great way to promote continuity of care. And then a little over 15 of you have a written. So about 15% of you have a written agreement. A fifth have informal relationships. So, collectively, that's over a third of you have some type of referral arrangement with an FQHC. So interestingly, going back to the call I had yesterday, this organization that's a Ryan White provider is trying to become an FQHC, and they're realizing the best way to do so in order to fill those gaps because it doesn't provide all those services I listed on the previous slide is to come up with a referral arrangement with an FQHC. So again, before you become an FQHC, you have to ensure that you provide all of these services, and this isn't even the full list. And if you don't do it directly, you need to make sure that you have an established written arrangement with another provider. That other provider can be an FQHC, assuming you have their support. Okay. I find when I speak to other safety net providers, there's a lot of interest in the quality improvement requirements that health centers are required to comply with. They are required to have an ongoing QI/QA program and set of activities that is run by a clinical director. This is particularly important for that Federal Tort Claims Act coverage that Emily had mentioned previously. There is great flexibility, however, for health centers to structure their QI/QA plan and activities depending on the need in their community, their scope of services, their size, their particular population served. You don't see a lot of rigid criteria from a HRSA requirement perspective in terms of how the QI/QA activities must be structured. In terms of the reporting, health centers report pretty extensive data through the Uniform Data System, also referred to as the UDS, and there are resources on the HRSA website in terms of the UDS. The UDS is what HRSA uses to get us those great numbers that Emily listed previously about how many people do health centers serve, what are their various demographics, et cetera. Health centers are also have various clinical measures that they report on, which are also on the HRSA website. I've been working at Feldsman+Tucker for about 8 years, and I've been seeing an increasing emphasis on these clinical measures and on quality and on documenting quality. Back in 2014, there was, I believe it was $36 million of grant funds to over 1,000 health centers to reward those organizations that somehow documented and were able to show that they had high quality indicators. And so indeed, HRSA is really emphasizing the importance of quality initiatives and the importance of patient-centered medical home designation. Those are just some interesting trends. The third topic I wanted to touch upon is the schedule of charges and discounts. A health center has to have charges that are designed to cover their reasonable costs and are consistent with locally prevailing rates. So that's relatively flexible criteria. It's not rigid, as you can tell, but I would say, the covering the reasonable rates is really a key one for purposes of ensuring that your charges are set in a manner to make sure that you are financially stable. I'm not sure I said this previously, but probably one of the biggest important requirements is that patients have to be served regardless of ability to pay and insurance status. So health centers are mandated to serve all uninsured who walk through the door, and they're supposed to receive the same treatment as all insured patients. So if we get a question, can we have a waiting list for somebody who's uninsured that's different somehow than patients with private insurance, Medicaid, or what have you, the answer is undoubtedly no. All patients have to be equally served regardless of ability to pay. Now, we have, as you see here, we have these schedule of charges. Now, you are all going to be very familiar with the concept of a schedule of discounts, although it looks somewhat different in the health center world. The criteria are as follows. Patients at or below 100% of the federal poverty level receive full discounts or can be charged at most a nominal fee. I've heard a number of people from other programs say health centers are mandated to charge a nominal fee for patients at and under 100%. That's not true. They can have full discounts. In fact, the way the regulations are written, it says they must charge they must have a full discount or charge at most a nominal fee. And that is a flat amount, not a percentage base. So you couldn't say you get a 90% discount. It would have to be a $10 discount. And then in terms of the slide, that's for patients between 101 and 200% of the federal poverty level. HRSA has said there have to be kind of 3 gradations of discounts in that range. So we can't just have one amount or 2 amounts for people in that range. There have to be at least 3. And those discounts have to, as you can imagine, become more significant higher as you get closer to 100% of the federal poverty level. And then for patients at and above 200% of the federal poverty level, there are no discounts using Section 330 dollars. Now, if you have another source of funding, whether it's Title X, Ryan White, what have you, then, of course, you can use those funds to discount above 200% federal poverty level. And I know that can be a challenge when you're an organization that receives funding from these multiple grant sources. Ryan White would say the discounts must be above 200. I can't remember the exact threshold. I know with Title X, I think it's 10 to 50%. Whereas health centers say the ceiling is 201% of the federal poverty level. Interestingly, I have heard of concerns between health centers and other providers that a health center is somehow prohibited from referring its patients to the other entity if the other entity provides discounts above 200% of the federal poverty level. That is not accurate. The referral requirements applicable to health centers, A, they only extend to required FQHC services, those services that are in scope. And B, the requirement is that the health center must ensure that the other provider can furnish services in a manner that at least satisfies the Section 330 criteria. And by that I mean it has discounts for patients at and below 200% of the federal poverty level. If another provider's sliding fee scale, its discount schedule, is more generous than what's required by Section 330, in other words, it discounts up to $250, $300, what have you, that is entirely permissible from a HRSA perspective. So those are the key points in terms of FQHC charges and discounts. Not all that long ago, it feels like it was just yesterday, HRSA came out with PIN 2014-02, and that PIN answers a lot of these kind of nuanced questions. Now, I think I saw a question. So are FQHCs required to offer preventive services rated A or B by, I have to admit I don't understand that question, rated A or B by USPSTF with no copayments? So health centers, if there's a copayment under Medicare, Medicaid, or private pay, the health center isn't mandated to waive the copayments. So I would say the answer to that would be no. There is, interestingly, a health center can discount copayments. So an individual who's insured pays no more than an individual who is uninsured would pay. But my word of caution would be before you waive or discount copayments by a private insurer, check the contract, check the payer contract to make sure that such waivers and discounts are not prohibited. So a scenario, the concept of a copayment and a deductible is that you're trying to prevent overutilization. So if you have somebody come in, Blue Cross Blue Shield, and there's a mandated copayment, a health center would be prohibited, not by HRSA, but under the contract, the health center may be prohibited from reducing that copayment. So you have to look at that contract. Hopefully that answers your question. If it doesn't, feel free to ask a follow-up question. And just as kind of an aside, typically the prohibition is on discounting or waiving copayments, not a must you discount a copayment. Usually it's a can we, and there actually is a safe harbor under the anti-kickback statute for health centers to discount or waive copayments for Medicaid and Medicare enrollees who are at and below 200% of the federal poverty level. And again, that's specific to Medicare and Medicaid. So there was a follow-up question. What perfect timing? What can patients do if they're refused service because they cannot pay? Let's actually go to the next question, next slide rather, and we'll see what people say, and then I'm going to answer that question. So this is one we get a lot. Can a health center ever deny a patient from receiving services? Yes, in limited circumstances based on unwillingness to pay. 2, in limited circumstances based on inability to pay. And 3, no, never. Looks as though most people thought the answer is C. About a third thought the answer is A, and a couple thought it was B. So the answer is actually A. In this PIN 2014-02, HRSA makes it clear that its formal position is that a patient can be denied services if, or they can be kind of terminated as patients, if you will, based on their unwillingness to pay. So that's A. Inability to pay is never an acceptable basis for refusing care. And no, never is interesting. I think most health centers take the no, never approach, and the safer approach is the no, never answer. But indeed, HRSA has said that it recognizes that if a patient is not unable to pay, but is unwilling, that a health center, if it comes up with very specific policies that are board approved, and we have an explicit process for how we determine unwillingness to pay, then it is permissible. Now, many health centers, understandably, and many of you are probably saying, well, how do we distinguish between unwillingness and inability? Now, HRSA doesn't tell you what that process looks like specifically. But, my guess, my example would be when I talk to people that are struggling with this is, has the patient refused, have you made many efforts to accommodate the individual? So have you tried to have them meet with a financial counselor? Have you tried to come up with a payment plan? And have all those attempts basically been futile? The person is unwilling to come to a process to discuss payment. And this, of course, would be relevant if, based on, after doing financial analysis, by looking at pay stubs, W-2s, what have you, there's a conclusion that the person is not unable to pay. They make adequate compensation to pay for their services, and you have made many attempts to sit with a person to try to understand, are there things going on in your life that are making it difficult to pay at this current time. But it's tricky, and you're always a little bit on thin ice because, as the next question is, what can patients do if they're refused services because they cannot pay? I would recommend that person try to meet with a financial counselor at the health center, try to come up with a payment plan. It's hard to answer that question without knowing the exact health center, and I don't want to know the exact health center's name, but every health center handles the inability to pay issue differently. So it depends in part on how that particular health center works with patients who have some type of financial challenges to paying the requisite fee. So more questions are welcome. I'm just kind of answering as they come in. I know we're getting close to time here. Okay. Health centers have every health center has a community-based board of directors. So HRSA is very specific about the criteria. A majority of the health center board members must be patients of the health center, which HRSA a little over a year ago explained is that an individual who has had a billable visit at the health center in the past 2 years, and an individual who is a parent or a legal guardian of a parent, who is a dependent child or adult or a legal sponsor of an immigrant, may also serve on behalf of the other individual as a consumer, aka patient representative. You'll see here that we have the definition of a visit for purposes of, again, satisfying this consumer representation. PIN 2014-01 is available and new and not quite hot off the press, but a great new resource if you'd like more information about the community-based board of directors. So the remaining non-consumer, aka non-patient members of the board, are representatives of the community and are selected for their expertise in various areas, so finance, legal, social service agencies, teachers are common. It's always very helpful to have 1 or 2 finance people. That's a big part of the board's responsibilities. But this is just kind of a list of areas that are helpful to have representation on the board, but it's not exhaustive, and it's by no means something where you have to check in every box that you have somebody from each of these areas of expertise. So within this kind of minority non-consumer member bucket of individuals, no more than half of them can derive more than 10% of their income from the healthcare industry. That is interpreted very broadly. So we could have somebody who works in pharma but isn't a provider. That would count. We could have somebody who works for a managed care organization. I think that could arguably fall within healthcare industry. In other words, you don't have to be a provider. This can get tricky if you have a hospital partner or some other organization that's another clinical provider that looks to become involved in your board. If you have 3 non-patient representatives on the board, 3 non-consumer members, only one of them can be from the healthcare industry. So if you have that one individual who is from the hospital, for example, then the nurse who is in the community and very involved but isn't a patient, she could not serve as a non-consumer member because that would put you above the 50% threshold. So this is something important to keep in mind. One of the important reasons I want to just touch on the community-based board of directors with this audience is because if you are looking to work with a health center, it's important to know that you may not just be talking to the board of directors. Health centers are very involved in not day-to-day operations, but decisions about scope of projects, collaborations with other providers, and so you may be asked to come and present to the board of directors or otherwise provide the CEO or other management with information to make sure the board is appropriately informed. All right, I am just curious if the majority of your board members are patients. That 14% of you answered yes, and I think that's about the percentage of you who are FQHCs. And then 64 of you said no, and then about a quarter of you aren't sure, which makes perfect sense. So that's an important thing to keep in mind. We'll talk about that during the next webinar, but this would be a significant area of consideration if your organization is not an FQHC and is considering becoming one. There are specific board authorities. I'm not going to read them all. I'll let you all skim them. But HIRSA is very rigid that the board is actively involved in the health center, in directing its strategic plan, in approving certain policies, in reviewing and approving the budget, as well as grant applications. The board is also required by regulation to evaluate the CEO on an annual basis. So last but not least, because I want to leave a little bit more time for questions, like 3 minutes, health centers must be autonomous corporate entities. It gets a little tricky when we're talking about I'm going to put the public entity model aside that Emily talked about, but you cannot have, it's very difficult to accomplish, a parent-subsidiary relationship where a health center is a subsidiary to another corporate entity. And the real challenge is that the board has these very specific, in-depth, autonomous authorities, and it's very difficult, if not impossible, and HIRSA definitely has said that it generally objects to parent-subsidiary relationships because the parent typically has authorities that undermine the board's authorities. You do see quite a bit of subrecipient relationships, however, not to be confused with subsidiaries, and that can be, a health center can be a subrecipient of Ryan White funds, Title X funds. It can also have subrecipients where it receives its grant and provides part of its grant to a subrecipient entity. So with that, I know I haven't left much time, but I'm curious if there are any questions. Okay, can HIV patients be turned away from an FQHC who are seeking primary care because they are HIV positive? I would believe the answer to that would be no, although that is probably a state law issue. I will look into that before the next webinar. What are the advantages of becoming a lookalike facility? So I would go back to the slide. I won't do it now. The slide that Emily touched upon. They get the benefit of the prospective payment system reimbursement, which is typically higher. They get to participate in 340B. It's important to note they do not have FTCA coverage, Federal Tort Claims Act coverage. Another benefit I would say is that lookalikes are historically more competitive than non-lookalikes because HIRSA is familiar with your organization, so you would become a lookalike and then you would apply for a grant. Does warning regarding waiving of copays, you just mentioned, also apply to FQHC pharmacy as well as services? So I'm not sure what we mean by warning. I guess my warning, the answer to that, well, it would be yes insofar as we're talking, yes, the answer to that would be yes. And by warning, I assume we mean that you have your contractual obligations with payers that must be abided by. And I think that is it. And I think I got all the questions. All right, thanks so much. Have a great day.